Everyone, welcome to our series of infections affecting the lungs. So in the last video we talked about tuberculosis, and in this video we're going to be talking about pneumonia. So pneumonia is a lung infection, and it is specifically an infection of the lung parenchyma, specifically affecting the alveoli and the terminal bronchioles. So this infection, it leads to inflammation and consolidation, making it difficult for oxygen to diffuse efficiently. So it can be caused by bacteria, it can be caused by viruses, fungi, or even parasites, and it usually ranges from mild to life-threatening cases, especially in vulnerable populations. So looking at the background, so pneumonia has been a major cause of morbidity and mortality globally, particularly in children under the age of 5 and in the elderly too. So it can come as community acquired pneumonia, which is caught outside the hospital setting or the healthcare setting, and it can also come as hospital acquired pneumonia, which usually occurs after, like, let's say 48 hours after hospital stay. Then it can also come as ventilator associated pneumonia, which occurs maybe due to long exposure to like AC or other kinds of ventilation. And then aspiration pneumonia, which is caused by inhaling gastric contents or inhaling food. So looking at the signs and symptoms of pneumonia, there will be cough, either productive or dry cough, fever, chills, chest pain, excruciating chest pain, shortness of breath, fatigue, crackles or bronchial breath sounds, and confusion, especially in the elderly, older adults. Then tachypnea, which is increased respiratory rate, and tachycardia too. So looking at the clinical presentation, it varies based on the causative organism and the host status. So for pneumonia caused by bacteria, that is bacterial pneumonia, there is sudden onset, high fever, comes with productive cough, with purulent or rusty sputum, and is usually caused by the organism known as Streptococcus pneumoniae. And then for cases with viral pneumonia that's caused by influenza, it has a gradual onset rather than sudden onset, and it comes with dry cough and a very mild fever. Then for atypical pneumonia that is caused by mycoplasma, so there is headache, there is sore throat, and there is non-productive cough. And then in this atypical pneumonia, if you check the chest x-ray that is done, there will be presence of diffuse infiltrates. So when you now have aspiration pneumonia caused by inhaling of gastric contents, there will be foul smelling sputum, especially in people with swallowing difficulties. So looking at the etiology or the cause of pneumonia is caused by a lot of organisms, and the common causative organisms, like for the bacteria now, Streptococcus pneumoniae, which is the most common cause of pneumonia can also be caused by Haemophilus influenza. It can be caused by, like I was saying, the bacteria that can cause pneumonia. So we have Streptococcus pneumoniae, which is the most common cause of pneumonia. Then Haemophilus influenza, Staphylococcus aureus, Klebsiella pneumonia, Mycoplasma pneumonia, which causes the atypical pneumonia. Then there is Legionella pneumophilia. And then for the respiratory viruses that cause pneumonia, we have influenza and adenovirus. And then fungi. Fungi usually causes pneumonia in immunocompromised individuals. So some examples of the fungi, we have Aspergillus and Pneumocystis jirovecii. So these fungi, they usually cause pneumonia in immunocompromised individuals. Then looking at the risk factors, so the risk factors of pneumonia: number one, very children between the age of 5 years, and the elderly. Then people that smoke a lot, presence of people that have this chronic illness like asthma, diabetes, heart failure. Then immunosuppressed individuals like people with cancer, HIV. Then alcoholics too are at risk of getting pneumonia. Then generally having poor oral hygiene, and hospitalization. People that are frequently hospitalized can be at risk of getting hospital-acquired pneumonia after they are discharged from the hospital. Then using of inhaled corticosteroids, and people that have swallowing difficulties are most likely to get the aspiration pneumonia. So they are at risk of aspiration. Then when we come to the anatomy and the physiology, so normal lungs, they contain alveoli, and these alveoli, they are air filled, and they are responsible for gas exchange. So in pneumonia, these alveoli, they become filled with fluid, filled with pus, and filled with cellular debris. So they also become inflamed due to immune response, and this usually impairs oxygen diffusion into the blood, leading to hypoxia and other respiratory symptoms. So all the symptoms we see in pneumonia is due to the immune response, the inflammation, which impairs oxygen diffusion into the blood, causing hypoxia and the various symptoms. So looking at the pathophysiology, first, there's the inhalation or the aspiration of the microorganisms. Then the microorganisms, they bypass the upper airway defenses, and then they reach the alveoli and trigger immune response. So when this immune response is triggered, inflammatory cytokines are produced, and they cause increased capillary permeability, they cause fluid accumulation, and they cause leukocyte infiltration. So the result is impaired gas exchange and hypoxemia, and potentially sepsis in severe cases. So when we're looking at the diagnosis, first, the patient history and physical examination for the various symptoms, and then there's a chest x-ray is done, and usually in the chest x-ray there's presence of lobar or interstitial infiltrates, and then complete blood count is done, which usually shows leukocytosis. Then other blood cultures are done too, and there's something called the urine antigen test, which is done to test for streptococcus pneumonia. And then for viral pneumonia, PCR tests can be done to check the specific virus that is causing the condition based on the genetic makeup. So looking at the differential diagnosis, like other conditions that could mirror this pneumonia infection. So we have pulmonary embolism, tuberculosis, like we talked about in the last video, bronchitis. Basically, conditions that affect the lungs too could mirror the same symptoms of pneumonia. So chronic obstructive pulmonary disease exacerbation to lung cancer, asthma, COVID-19. So these are basically all conditions that affect the lung tissue. So they can mirror the same symptoms that we see in pneumonia, but with differences in each of them. Like something that is particularly different in each of them. So looking at the management of pneumonia, so the general approach to therapy when we're trying to manage this pneumonia, so we have to confirm the diagnosis. We have to confirm if it's community acquired, if it's community acquired, if it's hospital acquired, if it's aspiration. Then we have to assess the severity of the pneumonia, and then we have to identify the risk factors and the comorbidities. Then we have to choose an empirical antibiotic therapy while awaiting cultures that we are getting from the lab to confirm the diagnosis. Then we also have to consider supportive therapy and monitoring. So when it comes to, first in the treatment, we just talked about the general approach therapy. So we confirm the diagnosis, we assess the severity, we identify the risk factors and the comorbidities. Is the person also having other conditions, other pre-existing diseases along with the pneumonia? And then we choose empirical antibiotic therapy and supportive therapy. So after we go through this general approach to therapy, then we have to look at the antibiotic selection based on the setting. So we look at the antibiotic selection based on if it's community acquired, if it's hospital acquired. So we look at this, and with this we are able to select the proper antibiotics. So when we're looking at the antibiotic selection based on setting, so first let's start with community acquired pneumonia. For like mild community acquired pneumonia and for outpatients. So usually community acquired pneumonia is caused by streptococcus pneumonia or mycoplasma pneumonia, and the first line oral options for this community acquired pneumonia, we have amoxicillin, high dose of amoxicillin, which is effective against pneumococcus. Then macrolides such as azithromycin for atypical pathogens, that is pathogens that are caused by mycoplasma pneumonia. Then we also have doxycycline, which is also a broad spectrum antibiotic that covers atypical infections. So in cases where the patient has penicillin allergy, we give either doxycycline or macrolides, but amoxicillin is usually the first line oral option. So when it comes to community acquired pneumonia that has moderate to severe, that is like moderate to severe, and the patient is hospitalized, like it's not an outpatient now, so here we have to give intravenous combinations like ceftriaxone combined with azithromycin, or we give a respiratory fluoroquinolone like levofloxacin. So if a methicillin resistant staphylococcus aureus is suspected, then we can add vancomycin to the combination. So looking at hospital acquired or ventilator associated pneumonia, the likely pathogens that cause these ones are Pseudomonas aeruginosa, Klebsiella, Escherichia coli, and Staphylococcus aureus. So in this case, we use broad spectrum antibiotics with pseudomonal coverage like piperacillin, tazobactam. So piperacillin, tazobactam is basically a combination of penicillin and what they call it, a beta-lactamase inhibitor. So we use this piperacillin and tazobactam, or we go for cefepime or meropenem combined with levofloxacin or amikacin. Then we also add vancomycin here in case of suspected methicillin resistant staphylococcus aureus, and we tailor antibiotics based on the culture sensitivity results. So the antibiotics that is more sensitive. So looking at the duration of therapy, most of the time uncomplicated community acquired pneumonia, we give therapy for 5 to 7 days. The hospital acquired, we can go for 7 to 14 days. So we usually stop therapy when there are no signs of infection, and or the patient has been afebrile for 48 to 72 hours, and if they have clinically improved. So supportive therapy that can be given is like oxygen therapy if the patient is hypoxic, then intravenous fluids for hydration, antipyretics like paracetamol in case of fever, then cough suppressants or expectorants as can be given too for the productive or the non-productive cough that the patient might have. Then in cases where the patient has persistent wheezing, we can give nebulized bronchodilators, and then nutritional support to in debilitated patients. So we when giving this therapy, we have to monitor the renal function, the oxygen saturation. So we just have to monitor the patient, and like how they make sure that they are taking their medications as they should. And so the preventive measures for this pneumonia, number one, smoking cessation, because smoking is generally very bad for the lungs. So smoking cessation is a very good preventive measure, sorry. Then proper hand hygiene, aspiration precautions in the elderly, and then using influenza vaccine. So mild cases of pneumonia, they usually resolve with proper treatment within 5 to 10 days, but in severe cases of pneumonia, it may take weeks to recover. There is high mortality in elderly patients, in immunocompromised patients, in patients that have delayed treatment, and in patients that have multi-drug resistant infections. So early detection, correct antibiotic use, and proper and support care, proper supportive therapy significantly improves outcome. So that is basically the breakdown of this condition that affects the lungs, along with pneumonia. Sorry, this condition that affects the lungs along with tuberculosis. So that is it. Thank you.